Okay. So today, as we can see, we are going to talk about stress-related disorders, right? So we'll be talking about stress itself, what is stress, then stress-related disorders. Then we have two classification systems, ICD-10 and ICD-11, which is official for India. The ICD-11 is recently introduced, and WHO has recommended that ICD-11 should be used now. And then we have out of these ICD-10 classification system. I've written those three important disorders and the stress-related disorders: the acute stress reaction, then the post-traumatic stress disorder, and adjustment disorders. Various categories of ICD-11. Slightly, there will be few differences. We will be talking about that later, right? So, what is stress? Psychological state associated with physiological and hormonal changes caused by conflict, trauma, or other disruptive events. So there are stressors. Because of the stressor, there are all kinds of changes happening, and that is what stress. The stress-related disorders are unique in that they are psychiatric diagnosis with a known etiology, the stressor. Stressor is common. Stressor has to be there with any of these disorders when we diagnose it. Right? In ICD-10, mainly of three types, as I told you. And ICD-11 has other few categories, like post-traumatic stress disorder is common in both. Then it is a complex post-traumatic stress disorder in ICD-11. Then prolonged grief disorder is another category. Adjustment disorder is common to both. Reactive attachment disorder is another category which is there in ICD-11. And disinhibited social engagement disorder. This is also in ICD-11, right? So first of all, the acute stress reaction. It's a transient disorder of significant severity, develops without any other apparent mental disorder, and responds to exceptional physical and or mental stress. And it usually subsides within hours or days. So it's a short lasting. Within 3 days, it is minimal. As far as the epidemiology is concerned, 15% motor vehicle accident survivors they have this disorder. 50% in women victims of sexual assault, and 33% in witness of mass shooting. Clinical features: there's an initial stage of days, including narrowing of attention, inability to comprehend stimuli, and disorientation. Then there is a withdrawal from the surrounding situation, flight reaction, panic anxiety, and autonomic hyperarousal can be there. Then depression, anger, or despair, that also comes. It begins to diminish within 24 to 48 hours, and as I told you, in 3 days it is at a minimal level. That's the acute stress reaction. The stressor continuum, immediate aftermath of an exceptionally stressful event. ICD-10 says traumatic, for example, rape, criminal assault, natural catastrophe, sudden changes in the social position and or network of the individual, for example, domestic fire, multiple effects. There can be a comorbidity of acute stress reaction with post-traumatic stress disorder, with depression, with substance use, abuse. These are the common comorbidities that lead to stress reaction. Etiology and psychological theories. There is a re-experiencing which happens in this disorder. It occurs because the trauma memory is inadequately linked to its context in time, place, and other autobiographical memories. So, person re-experiences the trauma, re-experiences the things happening, and whenever that person reaches into that state, anytime again, the re-experiencing can happen. Situationally accessible memory, which cannot be deliberately accessed, comprises sensory, physiological, and motor aspects of trauma in the form of codes that enable the re-experiencing of the original experience. So it is situationally accessible memory. Whenever a person reaches or goes or passes through the same situation again, for example, repeated assaults, whether rape, repeated rape, or violent assaults. So when one passes through that situation again and again, can we experience those symptoms of the acute stress reaction. Slow process that helps the traumatized person to adjust. Traumatic event shatters previously held belief. Post-trauma adjustment requires rebuilding basic belief about the self and the body. Biological theories. There's a lower cortisol level in the acute phase after rape. Excessive stimulation of the central nervous system at the time of traumatic experience. Acute arousal may have direct biological effects. Predictors of acute stress disorder, acute stress reaction, history of psychiatric disorder, depressive and dissociative symptoms prior to the traumatic event, and previous trauma the person has already gone through. The second, post-traumatic stress disorder, F43.1. It's a delayed and a protracted response to a stressful event or situation, either short or long-lasting, and of an exceptionally threatening or catastrophic nature. That's the nature of stress. Likely to cause pervasive distress in almost anyone. For example, natural or man-made disaster, combat, serious accident, witnessing the violent death of others, or being the victim of torture, terrorism, rape, or other crimes. Involuntarily, we experience aspects of the traumatic event as real also. Flashbacks are seen in which the person acts or feels as if the event were recurring. Nightmares. Nightmares, you know the difference between nightmares and night terrors? Nightmares are usually, there are dreams which happen and when the person wakes up from the dream. The dream is remembered what the person was seeing. That is nightmares. And night terrors are the dreams in which the person wakes up suddenly and he or she won't remember what the person was seeing. Usually, night terrors they happen in very young children. Sometimes they wake up past midnight and then terror and they start crying, incessantly. It's very difficult to console that. So here in PTSD, nightmares are there, where the person remember those dreams. Intense distress and or physiological reaction, and consequently avoidance. Avoidance is another category which is very important. It can to avoid situation, people, so avoidance is there. Emotional state, intense fear, anger, sadness, guilt or shame, emotional numbness, these are the common emotional states which are there. Detachment from other people. Hyperarousal can be there, hypervigilance, exaggerated startled responses, irritability, difficulty concentrating, and sleep problems, therefore, with PTSD. Anxiety and depression are commonly associated with above symptoms and signs. Now, these disorders, it's not only they are important in psychiatry, any part of life you are there, these types of situations, maybe somebody known to you is these types of situations, and they ask you, what has happened to the person. Know about the disorder, you would be able to tell. That's why it is important, not only from the psychiatric point of view. Now, this disorder should not generally be diagnosed unless there is evidence that it arose within 6 months of traumatic event of exceptional severity. So, within 6 months it should arise, and there is a period, lagging period, in between when the event has occurred and when the symptoms become. The lifetime prevalence rate is 10% in women and 4% in men. Estimates of PTSD in USA been seen as between 6 to 9%. Rates in the higher risk groups, for example, soldiers, it's almost up to 40%. Soldiers is very important. The stressor, out of the stressors, there can be any kind of stressful events. Rape was associated with the highest risk. That also is very important to know. Then the combat exposure, which happens to soldiers. Childhood neglect also can lead to this, and physical abuse also can lead to this. The sexual molestation, physical attack, torture victims, threatened with a weapon, kidnapped or held hostage, survivors of the Holocaust, they all have chances of going to PTSD. Psychological processes, fear conditioning, appraisal of the traumatic event and its sequelae, nature of the trauma, memories, fragmented and disorganized. So memories of the trauma usually they are fragmented and disorganized. They are not able to come out with the whole memory. A lot of times situational memory is there, and it's quite fragmented and disorganized. So part of it is different from that. In the biological processes, chronic stress reaction, enhanced secretion of adrenaline, noradrenaline, hypothalamic pituitary adrenal axis abnormalities are also there. The neuroendocrinological abnormalities, downregulation of adrenergic receptors, that's all biological processes of PTSD. Comorbidities of PTSD, various affective disorders, could be depression or various anxiety disorders or even bipolar affective disorder, then substance use disorders, somatization disorders, problems in family and marital adjustment. There are comorbidities with the PTSD. The factors that influence the risk of developing PTSD: female gender, personal history of mood and anxiety disorders, neuroticism, lower intelligence, lack of social support. So all those individuals with these characteristics, they have high risk of developing PTSD. Adjustment disorders. F43.2, again in ICD-10. Adjustment disorder is a state of subjective distress and emotional disturbance, usually interfering with the social functioning and performance, arising in the period of adaptation to a significant life change or to the consequence of stressful life event, including the presence or possibility of serious physical illness. So, this adaptation is very important. So whenever there is a life change, maybe a person changes the place of residence, or maybe a person changes the job, or maybe change of college, that can lead to adjustment disorder. And during an adaptation phase, this disorder will come. That is very important. It comes during the adaptation to the stressor, to the change. Whenever the change is happening. Clinical features, clinically significant and deemed to be in excess of a normal reaction to the stressor. A lot of times, normally people won't face any of these problems, but it is in excess to the normal reaction associated with impaired vocational and interpersonal function. So there is a change in residence, change in job, the functioning of the person also gets affected, change in college. So the student, maybe a good student in one college, then goes through poor performance in the new college, that can happen. Then there's a depressed mood, anxious mood, or mixed anxiety and depressive disorders. Disturbance of conduct, that's another important thing. Mixed disturbance of emotions and conduct. At the onset of this is usually within 1 month of the occurrence of the stressful event, whatever the change is, and not usually exceeds 6 months. The usual duration for adjustment disorder is 6 months. So within 6 months, they tend to disappear. But if they are treated, then sometimes they disappear early. Not treated within 6 months, the person tends to adjust. Epidemiology is 2 to 8% of the general population. That's the prevalence. Women are diagnosed with a disorder twice as often as men. In older people, found prevalence of 2%. Children and adolescents, boys and girls are equally diagnosed. In general hospital prevalence increased to about 11.5 to 31.5%. High rates also seen in people who made suicide attempts. That's another. People making suicide attempts, adjustment disorders are more. Or when you diagnose somebody with adjustment disorder, one should explore for the suicidality, or the suicidal ideas, and plans are there. That's very important. Stressors, health, bereavement, love and marriage, parent, family stressors for children and adolescents, family relationships, other relationships outside the family, work, school, financial, all these common stressors can be there with the adjustment disorder. And as I told you, most of these stressors, sometimes they don't bring out any disorder. People go through the stressors, they behave normally, and there are no problems. In ICD 11, we have these additional codes. Whatever we described in ICD-10, they are there. Then the additional codes like complex PTSD, prolonged or repetitive, extremely stressful event from which escape is difficult. Core symptoms of PTSD plus severe and pervasive problems in affect regulation. So in complex PTSD, this affect regulation is defective. These people, they suddenly, they have volatile effect. So suddenly they are angry, suddenly they are depressed, or maybe euphoric at times. So you find affective dysregulation. Persistent beliefs about oneself as diminished, defeated, or worthless, shame, guilt, these are also common with the in complex PTSD. Then we have another additional disorder, prolonged grief disorder. It is coded as 6B42 in ICD-11. Persistent and pervasive grief response characterized by longing for the deceased or persistent preoccupation with the deceased, accompanied by intense emotional pain. For example, sadness, guilt, anger, denial, blame, difficulty accepting the death, feeling one has lost a part of oneself. So that's called prolonged grief. Then there's a longing for the deceased, and then all the associated features. An inability to experience positive mood, emotional numbness, difficulty in engaging with social or other activities. The grief response has persisted for an atypically long period of time following the loss, more than 6 months at a minimum, and clearly exceeds expected social, cultural, or religious norms for the individual culture and context. Normally, the grief reaction is within few weeks, the grief tends to diminish. But here, it is more than 6 months it continues. Then we have reactive attachment disorder. This is characterized by grossly abnormal attachment behaviors in early childhood, occurring in the context of a history of grossly inadequate childcare, severe neglect, maltreatment, institutional deprivation. So whenever you have a gross maltreatment or gross neglect of the child, then it can lead to reactive attachment disorder. Even when an adequate primary caregiver is newly available, the child does not turn to the primary caregiver for comfort, support, and nurture. Rarely displays security-seeking behavior towards any adult. Does not respond when comfort is offered. It can only be diagnosed in children, and features of the disorder develop within first 5 years of life. It has to develop within first 5 years of life. And it cannot be diagnosed before the age of 1 year or a developmental age of less than 9 months, when the capacity for selective attachment may not be fully developed, or in the context of autism spectrum disorder. So when autism spectrum disorder cannot be diagnosed before 9 months, can never be diagnosed. 1 to 5 years is the common. Sometimes between 9 to 12 months it can be diagnosed. When selective attachment child has already developed. Then there is disinhibited social engagement disorder. It is characterized by grossly abnormal social behavior occurring in the context of a history of grossly inadequate child care again. The child approaches adults indiscriminately, lacks shyness to approach, will go away with unfamiliar adults, and exhibits overfamiliar behavior towards strangers, can only be diagnosed in children, and features of the disorder develop within first 5 years. Similarly, within first 5 years and then first 9 months can never be diagnosed, within 9 to 12 months sometimes can be diagnosed. However, the disorder cannot be diagnosed before 1 year. Or similarly, autism spectrum disorder. So in autism spectrum disorder also, this attachment difficulties are always there. Child is having difficulties in attachment, communication. So similar kinds of symptoms are there, and that needs to be ruled out whenever you are diagnosing this also, the disinhibited social engagement disorder. Now, let's summarize. First of all, the stress-related disorder. Stressor is must. For many users, this won't lead to a disorder. You already know. Then we have acute stress reaction. It's only ICD-10. Transient, subsides within hours and days, minimal after 3 days. And pre-experiencing of the trauma, the symptoms of trauma, the trauma, whatever is happening, that also is one of the hallmark of this disorder diagnosed. PTSD is there both in ICD-10 and 11. It's a delayed and a protracted response. Flashbacks are seen, nightmares are seen, detachment is there, and hyperarousal also can be there. Onset is within 6 months of the trauma. In rare cases, we have highest PTSD. Complex PTSD is prolonged or repetitive, extremely stressful event from which escape is difficult. Core symptoms of PTSD are there, plus severe and pervasive problems in the affect regulation, persistent belief about oneself as diminished, defeated, or worthless, shame, guilt, all these features are there. Then we have adjustment disorder. It's there both ICD-10 and 11. During adaptation. So adaptation is the key word. It only happens during the adaptation to the change. Whatever change has happened in a person's life, whatever stressful health change has happened. Disturbance of emotions and conduct is also associated with this. Onset is within 1 month, and total duration is usually not exceeding 6 months. Then prolonged grief disorder, ICD-11 only, 6 months minimum. Persistent grief, longing for the deceased, intense emotional response. And reactive attachment disorder, again ICD-11 only. Grossly abnormal attachment, grossly inadequate child care, first 5 years of life, not before 1 year. Rarely displays security seeking behavior towards another. Then disinhibited social engagement disorder, grossly abnormal social behavior in the context of inadequate child care, no shyness, diagnosed in first 5 years of life. Now management. These management, various psychological treatments like debriefing, counseling, cognitive behavior therapy, family therapy, group treatment, education, self-monitoring of symptoms, anxiety management, supportive psychotherapy, then psychopharmacological treatments, tricyclic antidepressants, SSRIs, monoamine oxidase inhibitors, anti-adrenergic agents, propranolol, clonidine, benzodiazepine, anxiolytics, and hypnotics, all these. I mean, we'll be talking about management. the next. Thank you. Any questions? Any questions?